Good afternoon and welcome to our town hall number 3. We are talking about surveillance testing and the pediatric algorithm today. Thank you for all of you who submitted questions prior to this town hall to COVID-19 at VSSNA.org. Out of respect for our presenters, please stay muted during the duration of this presentation today and put any questions you have in the chat box. We'll add them to our queue of questions and take questions after the presenters have finished. Any questions we are unable to get to due to time constraints, we will get a Q&A posted as well as the video recording of this town hall to our website, so you can view it at your pleasure later. And our town hall will be our next town hall won't be until October 14th. So we just want to put that out there so that everybody knows that our next town hall will not be until October 14th. Our next board meeting is October 16th. And we are hoping, our hope is that the local offices of health and our school nurse liaison team will appoint a school nurse from your region to be a VSSNA district rep on the board, and that all the reps will be present at that October 16th meeting. So if you have not already met with your school nurse liaison, please remind them and that we do need a district rep from each office of local health. So without further ado, I will present our speakers. Today we have a panel of experts speaking about surveillance testing, and that includes Jill Briggs Campbell, who's the COVID-19 Federal Emergency Funds Project Manager at the Vermont Agency of Education. Brooke Jenkins, who's the COVID-19 Response Testing Coordination Team member at the Vermont Department of Health. Drew Williams, who's the Interim Testing Manager at CIC Health. Stephanie White, the Senior Operations Coordinator at CIC Health. And Gary Mobley, Director of Testing Operations at CIC Health. Thank you so much for joining us today. We will be hearing from our experts from now until 4:45, and then we will be hearing from Brina Holmes from 4:45 to 5:30. Brina joins us today. She is the UVM Senior Faculty Member of VCHP, and she is going to guide us through the pediatric algorithm today. So without further ado, thank you, panelists, for the surveillance testing.
Thank you, Becca. So I'll jump in. Experts feels like a lot of pressure. So I'm Jill Briggs Campbell from the Agency of Education. In addition to my federal emergency funds hat that I wear, I'm also work with Ted Fisher on the COVID-19 response team, and was one of 4 folks at the agency that helped to stand up the original school surveillance testing program last fall. So I've spoken with a lot of you over the past year. So first off, I want to thank you all. I was actually just on the phone with your colleague Maria from Washington Central, which is why I was a couple of minutes late, so I apologize. I just want to thank you for the extraordinary work that you are all doing right now. I don't think that any of us really had hoped that the beginning of the year was going to look like this, right? We certainly weren't anticipating this in May and June, and you know, times are definitely interesting over on my end of things as well. Actually, as a parent, just got a notification that there was a positive case at my kids' elementary school. So I'm feeling it on both ends. So just wanted to really acknowledge the work that you're doing, and to definitely acknowledge that the situation with COVID-19 is so fluid right now that it's really changed the emphasis around this testing program. So I want you all to know that we are feeling that on our end, and we know that you are feeling it on your end. We understand, and we are hearing loud and clear that bandwidth, time, capacity is probably the biggest obstacle that you are all facing right now in getting the COVID testing program kind of getting onboarded and thinking about how you're going to actually stand this up and be successful. So I want you to know that we are hearing you, and that we are working pretty feverishly on our end right now to try to surge our own capacity to support you, to also identify ways to streamline the process to meet needs that you are telling us that you've got, and then also to gather data and information from you all about particularly around staffing needs. What do you need in the field to be able to sustain this program successfully? So my job right now is just to give some really brief introductory remarks, and then I want to hand it off to the CIC team and then leave plenty of time for questions. But some things I wanted to make sure that we sort of hit, because these have been sort of themes that have come up over and over in questions. So the first of those is that we do understand, and we are hearing very clearly, that the interaction between contact tracing and testing and positive results is something that needs to be, work needs to be done on that. And Secretary French actually very clearly acknowledged that in a call with the superintendents earlier today. There are active conversations that are happening right now at the highest levels around policy. And we understand and acknowledge that increased testing will yield additional cases and more contact tracing. And the AOE and Department of Health are currently discussing the school contact tracing program with the intention of reducing the burden to districts and schools. We really want to encourage you to not decline participation in the testing program due to contact tracing concerns, but we want to acknowledge that those concerns exist. So that's the first thing I really want to emphasize. The second thing is want to clarify sort of with this group here. It's on our website and we've put it out in communications, but I just want to reiterate this because the policy has shifted over time. So clarification that testing does not need to be supervised by someone with medical training, only someone that has completed the CIC training. And this includes children age 5 to 7. They are able to administer and self-swab and do not need to be supervised by a medical professional. And actually our team from CIC has some really kind of fantastic data to share with this group that we hope will sort of help to alleviate some of those concerns around those younger students. And then the last thing I want to do, because I really do want to leave as much time as possible for CIC and then for questions, is I just want to tell you some of the things that we are doing right now. And this is literally like in the last week that we've been working really quickly to respond to what we're hearing from the field. So one thing that we've done is the AOE team, and with support from Brooke from VDH, has reached out and done some really targeted outreach to districts. We've specifically identified a list of districts that already had positive cases to really sort of prioritize that group. But to identify technical issues, and CIC has responded with a surge in staffing to address those obstacles, because we were hearing that there was a lag time when folks were reaching out to the support desk. If you are having those technical issues, we encourage you to please let us know. We can't respond effectively if we don't know what those issues are. So CIC is responding though to those technical issues. The second thing is we had a request to draft a template letter for families to go with the consent form. CIC has just provided that template letter today, so I just want to thank them for that really quick turnaround. And so that's going to be available. You can send that, the consent form sort of describes the program and how it works, but this is sort of a letter that goes with it that explains why testing is important and what they can expect. We've also heard that in addition to the sort of website that we already have up on the Agency of Education, that it would be helpful to have one that's targeted specifically for school staff. So I'm actually drafting the copy on that today, this afternoon, and this evening, with the intention that we get that stood up. So it will have, and we did a similar thing with staff surveillance testing last fall. So this will be familiar. So there'll be a sort of more public-facing one that is more geared towards families and sort of a general thing. And then there's going to be one that will have sort of specific resources and frequently asked questions for all of you as you're standing up this program. So that will be coming very soon. We also have, we've sort of surged our capacity on both the AOE and VDH side to make sure that we are turning around any questions that come into our AOE COVID testing inbox, which you're all familiar with from last year. So keep using that. I would say, please use that as opposed to reaching out to maybe some of the staff that you spoke with for surveillance testing last year, because all they're doing is they're forwarding it to that inbox. And then there's a, you know, myself and Brooke and Amy Scalabrini, who you all worked with last year as well, we're the ones who are kind of on point with that right now. And then the last thing I want to plug, and I'll be sending this out, or our team will be sending this out, is we are hearing a lot of different information around what you all might need in terms of personnel support. So what I wanted to let you know, and CIC can talk about, and is going to talk about this a little bit more, is that we do have the ability to add staffing to support the field. That is part of our state support here. And there are sort of two flavors of that, I'm going to call it. One of those is sort of a district level sort of administrative and logistical support. And a few of you have identified that that's something that you could use, right? Just sort of take some of the burden of doing all of the logistics and like the bank system and all of that, take some of that off of your plate. Others of you have identified that you need bodies on the ground on testing day, particularly if we're looking at weekly testing, that, you know, just your ability to staff that up one day a week, every week is just going to be not within the realm of possibility right now. So I was resisting sending out yet another survey to you all because we're looking for a lot of information right now, and I hate to do it to you. But what we're finding is that our answers are so varied that I'm sending you a survey. So really simple two question survey, and we'll send it out on the COVID coordinator and the superintendent's email and the independent school list so that we kind of get everybody. But it's basically a two-part question. So can you use that sort of district level administrative logistical support, someone to help you with outreach to families, making sure consent letters are coming in, making sure that, you know, kind of your on testing day, you've got all of your sort of systems stood up and ready to go, or it's not a one or the other. In addition to your own sort of in-house staff, do you need some additional bodies on the ground on testing day? And if so, please give us a number. And I just want to signal, it can't be 50. You know, we don't have the capacity for that, but if you can give us a feel for what you would need to be able to sustain testing successfully. So that will be coming your way. You can turn it around quickly. That's great. We just need that really solid data right now so that we can do some decision making between CIC, VDH, and AOE. So that is all I'm going to say. I went as quickly as I possibly could. I'm going to hand it off to my colleagues at CIC, and I'm hoping that they can answer some of those questions and that I know are floating around, and then we'll leave it open to your questions as well. And I'll be using any questions that come in here to generate FAQs on the website we're standing up. So again, thank you all. Please always feel free to reach out. We want to help you get through the obstacles, and many of you have my cell phone now and you're making good use of it. So continue to do so. So thank you all. Gary or Drew, I'm not sure which one of you is going to take points, so I will hand off to you.
I'll take that. Thank you, Jill, and thank you everyone for having us. Yeah, we certainly understand that the nursing role existed within schools before COVID. There's a full job behind that, and then throwing on swabbing and everything can be a lot. So we're here to help with that. We are very glad to have you in the program. I'm going to go through sort of a bit of an overview, but more of like getting through some trouble points that we've seen so far. We have this great technology platform. We have this great additional support piece, and that's awesome when they work perfectly. However, right now, there are admittedly some issues. And so, as Jill alluded to, we're adding resources to sort of break through those barriers, break down those walls, and make it easier for everyone here to perform testing and get through a successful school year with as few cases as possible. So I'm gonna share my screen now. As I'm talking, please put questions in the chat. All right, so I have to do the obligatory ask, can you see my screen? Yes, okay,
sure can,
cool.
Drew.
Thank you. So let's start from the beginning, in case this got lost in the shuffle of everything starting up. So what are those onboarding steps that really need to take place? So almost every district, I believe, and many independent schools have submitted intent to participate. Following that submission, you should have received 3 pieces of information. So if you were in the early batch, you actually only received 2 emails. You received a welcome letter and a testing portal invite. If you're in the early batch, and it's hard for you to know, and I'm going to explain the solution we have for this right after, but you received a welcome letter and testing portal invite. Within that welcome letter, there was a unique code. And that code is a added layer of security that gets you into the school and consent database. If you were added a little bit later on, you received a 3rd email, and that email came from noreply@appsheets.com. And that was where you had your school and consent database code. It's, I think, 6 digits, maybe 8 random digits and numbers and letters. And we will be resending out that unique code tomorrow afternoon, just so that everyone's aware, just so it'll be fresh in everybody's inbox. We'll be following up with the newsletter tomorrow with more information on that, just so you're aware and aren't like, oh, what is this? Another email. But after that, so you use that portal invite to log into the portal, and we're going to do a walkthrough right after this on a high level. And you can go within the portal anywhere you'd like. You can browse it. It's all that's in there are resources for you. But I recommend going to how to use the portal. It's the first box on the left, and that gives resources on how to use the portal as a whole and what's in there. Next, I would recommend going to the onboarding quick guide, which is within that how to use the portal bucket. That's a checklist and it's interactive. So it gives an outline of the steps you'll need to perform the testing. When you toggle the switches on and off to check off that you've done something, it also notifies CIC Health of your status on that. So we can see if you're stuck somewhere. You can see if you haven't been able to utilize this tool. You can see if you're just about ready. So it's a great resource. Next, in that school and consent database, where a lot of the issues are arising due to this extra code, I'd recommend you go there and make sure that you put that correct code into the system. We are able to re-email you out that code at any time. We'll just email it to the district coordinator email. Just contact our customer support to do that. But like I said, we'll also be emailing that out tomorrow afternoon. So within the school and consent database, you can fill in the information about your district and the schools within your district. You can designate school coordinators who will be the person on the ground at each school administering this program. You can also select your preferred start date. And we recommend that you do that as soon as possible. And we will try to honor that preferred start date as best we can. We encourage you to make the start date, as soon as possible, that you feel that you'll be ready to perform the testing. And then there is also a section of training resources for testing, which is a written out walkthrough of how to go through a testing day, how to use the software. There's also some video tutorials there for you. And then from there, you can continue just going through that checklist that helps guide your process that I mentioned in step 3. And we're also continuing to add to the portal. I know some people are looking for resources, as Jill mentioned, a letter to send out about consent, perhaps some other outreach that can be used to communicate to parents in your community about the testing at school. That will start living in the portal as well. And we are also, just like the AOE is building a different landing page for this at CIC Health, we are working on the Vermont landing page within our website, which will be public facing. You won't need to log into a portal to see any of this information. And it'll be full with resources for the community as well. And then you can see at the bottom, the onboarding takes an average of 10 hours to complete. Could be a little bit more, could be a little bit less, but that's what we've found in the past. So now I'm going to stop sharing for 1 second, and we're going to do a portal walkthrough. I'll share again. So if you've logged into the portal correctly, you'll see this screen. This screen might look a little different to some people who have been logging in because we've continued to add to it. So we now have this community resources bucket. That's still getting filled, but you can see it here. This is that how to use the portal that I was talking about. There's some information here, some kind of high level information for your program. If you access the quick onboarding quick guide, this has that checklist that I was talking about where you can toggle on or off. And if you go back, we also have the training resources here. So if you click through, you can see, an overview of what this program is, what really is my role within it. For example, what happens on testing day? I'm collecting the samples. How do I do it? Here's a video on how to do it, and so forth. Over here is the administrative tools. This is where you see that school and consent database I've referenced. I'm not going to log into it because there's PHI once I open it. So just so you know, you would click that button and put in your email that you signed up for the program with, that you used to enter the portal, and then that unique access code.
Drew, I'm happy to walk through that really quick if that's helpful. I have a testing.
Oh, JP, you were here. Okay. You might not have screen sharing capabilities, but 1 second.
Yes, he does.
He does. Fantastic.
Okay.
JP is also on our team and is a genius and I'm not even sure what his title is. He's just kind of Superman right now. So take it away.
Hey, everybody. So like Drew mentioned, this is the school and consent database. So there's a few different tools here. I'm in a test account currently, but when you log in with the code that Drew mentioned previously, for those who do not have that code, we will be sending it out again tomorrow. you'll be taken to a screen that looks like this. That'll show your SU on this first page. You'll be able to click into your SU and edit any information that looks wrong and add additional information. So this one already has a bit of info here. So we've got the test SU. We said it was in Franklin County, contact name, phone number, but some of this won't be populated for you when you launch yours. So I would just advise clicking right into the row. So you can click anywhere here and then hitting this big edit button here. And it'll allow you to edit certain things about your district. So you can change the county. If you need to, you can add in a supply hub address. You can fill in your preferred start date, as Drew mentioned previously. So you can add in 27th. Your testing day will be assigned based on your county. So that'll fill in here. And there's a few other things you can add in additionally. So once you're done there, you can just hit proceed. Oops, I'm not going to do it because I'm not going to put in a supply hub address. But then once you do that, it'll save to your profile here. You can also add schools to your SU. So I know some of you are managing multiple schools and you'll be able to add those here. So I have 4 schools as a part of this SU, but if you need to add another one, you can just do that big plus, choose your SU, add your school name, and add a little bit of information about that school. You're also able to add site coordinators as well. So if there's additional people who will be helping out with the program, you can add those here. So I've got a few test people in here for these different schools, but what you can do is actually just hit this plus button, add the school that they'll be associated with, add their email in, their phone number, and then you can actually designate which level of Binks access they'll need. Drew, I'm not sure if you've touched on this already, but there's 2 options here, just a full access level admin view, and then just the sample collection admin view for just registering tubes on site.
Thank you, JP. No, I did not touch on that, but yep, that's a good point. So if you saw there, this is, you imagine JP walking through this as a district coordinator or the COVID coordinator, who's going in and adding coordinators at each individual school. So the district coordinator has the ability to give results viewing access to the school coordinator, or just simply the ability to perform the test in the software without seeing the results. So thank you, JP.
Yeah, thanks, Drew. And then the last piece is just looking at consented individuals. So we have 2 tabs. There's 2 forms circulating currently. One is an adult consent form. So those will populate here. I actually don't have any in this test environment. But then there's also the student consent data, which will be populated. So you can see here it says test SU has 10 records. So I'm going to click into that. And you can actually see those right here. So we've got a couple of just tests in. And you can just see the first name, last name, sex, date of birth, race, kind of all those questions that came from the consent form. So those are all available to you here. You can kind of quickly scroll through. If you do ever need to access those consents, what you can do is actually click into your schools tab here. You can click into, so I think it was test school that had all those consents. And you can actually email the school consent to yourself. So with that big orange button in the lower right-hand corner with the little paper airplane, if you click that, it'll send you an email with all your consents in a CSV format.
Thanks, JP. And some schools have found that valuable to organize on testing day, to download the consents onto a CSV, so you can easily sort, with multiple columns as you're going through testing during the day. You can put it into Excel, you can put it into Google Sheets, whatever spreadsheet you prefer.
Yeah, thanks, Drew. And then I will just touch on one thing. This is the login screen. So I just put in this test code here, but this where it says password, that's your code that you received. This has been a little bit confusing for some people. So I know you do log into the CICH-vermont.zendesk.com first, and you click your way through to get to this tool. But once you do get to this tool here, it will ask you for this password, and that is that code. It's like a 5 or 6 digit random code, and that's what you'll put here. So if you don't see this screen when you log in, all you have to do is click this, the 3 menu buttons or the 3 lines in the upper left-hand corner. So you would click that, you would hit login, and then just make sure that code is here. If it's not here, you might see a white screen. So just make sure that that's set up properly.
Awesome. Thank you, JP. Anything else? No.
I think that's it.
All right. So I have, thank you very much for joining. And stick around if you can for some questions if you're able. Let me get back to the slideshow.
And Drew, not to hustle you, but Dr. Holmes is going to be coming on at 4:45, so we want to leave some time for Q&A. I am good. Hustling you, but
well, yeah, that's fine. I'll just go real quick through these next 2. So available support. We have webinars ongoing. We have office hours every Tuesday and Thursday in September. Basically, you just click this Zoom link. We'll get this slide deck out after, so you have all these links. You should also be receiving email newsletters with them. Then we have our contact information there. So I have some FAQs built in here, but perhaps we should address the questions in the room first, given the time, although some of these might help out. So let me go through some of the more pressing, frequently asked questions. So I think some of these newer ones on this last slide here. So many of you may be aware that there's a paper tracker that's mentioned in the learning documents on that portal. The question is, do we have to use it? And so the answer is no. The paper tracker is optional. What it does is it allows the lab to process tests that aren't properly registered. And that's just a human error thing. It used to be more common in our testing, but actually we've looked recently and this only affects 0.06% of samples. Now that is the risk for you to weigh. There you do run the chance that you perform a test and the sample comes back and it's not registered. We have no way of tracking it. We can't issue a result. So we do have this additional tracker. It can be digital as well. You can use the scanner we'll provide you to enter the data into a spreadsheet. So just something to keep in mind and maybe save a headache or some time if you are willing to take on that chance. Next is the school responsible for reporting results to parents and guardians. I know Jill touched on this. I'm saying here that the testing software presents the result to the parent and guardian at the same time that it presents the result to district coordinator and the VDH. So, I mean, I'll defer to the VDH, but in my understanding here, the parent and guardian is getting notified, at the same time as anyone else is. So the software itself takes care of that notification. And then, as Jill mentioned, should we really have young children self-swab? And I can send out a further expanded case study on this, but this happened in the spring of last year. We studied over 16,000 samples, and we found that grades 2 through 8 actually generated meaningfully fewer failed sample collections. I believe 16.8% fewer failed sample collections when the students self-administered the test versus having somebody swab for them. And then further, kindergarten and first grader, there was smaller sample size, but there were 0 failed collections. There was 1 failed collection in the previous 655 samples that were collected with that same group. So again, a small sample, but no noticeable change. Definitely not a worse result. So, overall, kids are great at picking their noses, and they actually do a really good job on this themselves. So with that, I will open it up to general questions.
So the first question goes back to the beginning of the presentation about, are there any videos for parents and students about the testing, as well as the forms and letters that you wrote, are those available in other languages?
Yeah, so the letters, no, not right now, but please let me know what languages you need and we'll work to address that. I know somebody's requested the consent forms in different language. Those are legal documents, so they take a little longer to produce in a different language, making sure that everything holds up. But if you do need a specific language, please let us know. And we have a team that can work on that. And those videos and everything will be made available on the portal, as well as on the Vermont landing page within CIC Health. But also we've given some of those videos and information to the state as well that they can host.
There's a question about, will CIC be using pooling method of testing, or is it just individuals?
Yeah, it's only individual testing. Some of the materials that were already created were created for pooled testing earlier on, but we're doing individual testing, and the pooled testing it's pretty much the same process on swabbing day, but it is individual testing.
And for those who tested in the spring, will they need to do the onboarding process again, or has it already been done?
So those districts will still need to be onboarded into this portal. We didn't have that in the spring. So that part does need to happen again. But like the training would be very similar for the actual software.
And there's a specific question about, is the second code entered after having entered the portal with the password?
Yes, so you to enter the portal, you received a link where you created your own password using your email. So that gets you into the portal, which is that overarching website. And then to get to that specific part that JP was really walking through with the spreadsheets and everything, that's where you need that unique code that's provided to you by CIC Health. And if you've lost that code, we're going to send it again on Friday. And if you are still having issues, please reach out.
Can districts choose to test only staff and not students?
So the program, as far as I'm aware, maybe Jill, you can fill in here. It's open to anyone who's a staff or student within the school ages 5 and up, but we don't mandate that anyone, receive the testing. I don't know if
Jill,
that
do you want to jump in on this?
Yeah, so Drew, I would second that. It's an opt-in program. It is available to anyone. I think that we have heard from 1 or 2 districts that they're sort of interested in just doing staff testing. I'm going to encourage that everybody be involved. And I think that we could also look at this as a potential really powerful tool for things like athletics and music and that sort of thing as weekly testing being part of the equation in terms of some of those more, what we've sort of characterized as more high risk or sort of close contact activities. So that is ultimately, it is a decision. There's no mandate around this, just as with our previous testing program, it's an opt-in program. So, but we would encourage that, and it could even be that you start with staff surveillance testing because that's what you have the capacity to do. And as you get your feet under you, you expand it out for students. So that may be, you know, if that's something that actually helps you to get this process going, you know, please, yeah, you know, do what feels best for you in terms of being able to get your feet under you, and then we would strongly encourage you to offer it to everyone.
I would add to that too, just from the VDH side, to reemphasize what Jill is saying. We know that testing is just one of many mitigation strategies that your school is probably using to combat COVID in this time. But it is a really, really critical one. Ultimately, you won't know if COVID is spreading in your school unless you test people. And at the moment, kids can't be vaccinated, right? Like under a certain age, those kids are not vaccinated and they're potentially the most vulnerable here. I think that from VDH's perspective, some testing your staff is better than not testing anyone, but we would definitely push and encourage you, if you're able, to offer that testing for students as well.
Thank you. Will we need an individual at every school to collect and transport the tests?
So Courier will come to each school individually on test day and transport those collected samples to the lab. So there will be people within each school doing the testing, administering the testing on test day, whether that's a person roaming from school to school, or a group of people roaming, or dedicated people within the school. That's up to you. But in terms of transporting the test to the lab, the courier will come to your doorstep.
Does testing have to occur on one day for the entire district, or can we spread it out throughout the week in different buildings?
Yeah, so in order for the logistics to work, it all has to happen on the same day. So your district is assigned to one of 4 quadrants based on location in Vermont, and you have a dedicated testing day. You can have your school's test on that day, but that's the only day of the week.
So Drew, just to add a little bit of nuance to that, if you are going to use the courier service and have the shipping paid for, you do have the option to test on to spread it out, but the shipping costs will have to be picked up on your end, not by the state. However, I'm a federal funds manager. We have lots of ways to pay for that. So, you know, you can use ESSER funds, you can use FEMA funds, contact me. Also, any of your staffing costs associated with this are all eligible costs under those federal emergency funds. So when it comes to that, please reach out to me. I'm your point of contact for that.
And also, I'm conscious of time. It's 4:44. We have office hours tomorrow. We have webinars going on. Wednesday, or sorry, we have a webinar tomorrow, is Friday, and office hours on Tuesdays and Thursdays. And that information, you'll be receiving a newsletter if you haven't already, with links to those events. And you can also just reach out if you don't have the link.
Thank you so much for your presentation today. All of the rest of the questions in the chat, or any other questions, if you have any about surveillance testing, please send them to covid-19@vssna.org. We'll be sending these questions to our presenters today to create a Q&A to put on our website.
Thank you. Thank you very much.
Thank you so much for coming and speaking to us today.
Thank you.
Gary, did you want to say anything? You didn't say anything.
I just wanted to make sure you got all the information out. And I just want to say we're here to support you. And if another form like this is necessary, we do that too. We want to make sure you answer your questions, and we do what we do, get kids tested, get our people tested. So that's all.
Thank you so much. And now we're going to turn it over to Brina to go through the pediatric algorithm and answer any questions that we have about that. Thank you, Brina.
Okay, hi everyone. Wow. These are two big complex topics in one busy afternoon. I just wanted to acknowledge that. I'm going to share my screen, and in doing so, just want to start by saying I can't believe we're back here. Our commitment remains the same, except that there are a lot of different pieces this year. And I just wanted to acknowledge that I no longer work at the health department. I am a general pediatrician. For those that part wasn't clear. And now I'm over in the Department of Pediatrics, but I maintain a pretty important role in the American Academy of Pediatrics as one of their officers, and really trying to do the bridging between this shift that we started to make last spring together, which is we're now in pediatric healthcare advice about COVID in children in the absence of a lot of public policy or mandates, which you obviously have been living this past week. I do want to also acknowledge that the health department is working really hard to catch up with what needs to happen here. And I was really glad that Jill led with that. And just you continue to have all of us, both the pediatricians and the teams at the health department. And I don't want you to feel that all of that has shifted. I think it's just, I heard Dr. Levine speak to the Vermont Medical Society today, and he was just saying, it's just, we thought we were going to have a little bit of a different August. Delta turned out to be a much more formidable variant. So let's just start with that. Take a breath. That testing piece is a really important mitigation piece. Complicated, but maybe not. And Megan's last chat is probably the most helpful, which is that the webinars will be smaller groups where you can really get your questions answered, because it's I'm sure it's weighing heavily after the last 45 minutes. So I wanted to start with Emerson, because I feel like this place that you hold in our COVID response is we're standing on remarkable success from last year, which we attribute to your greatness. And I mean the collective we, but most especially your pediatric colleagues. So this quote about laughing often, I'm sure there's not a lot of humor, but please use it if it helps you cope, as it does me. I want you to know that you have won the respect of all the intelligent people in this response. Obviously, your whole, life work is the affection of children. There's been a lot of opportunity for school nurse leadership in this pandemic, and this, being able to endure the betrayal of false friends. That's pretty hyperbolic language, but you've had very difficult relationships and conversations with both administrators, parents, and even public health folks. And we've all learned a lot about sort of the beauty of the messiness. And then obviously keeping children healthy and redeeming social conditions. That's who you've always been and continue to be. So I just wanted you to know that you should rest easy every night, that you have helped others to breathe more easily, even if the day was quite messy. And now I have to figure out how to advance my slides. Okay, I'm going to close down a few things so I can see better. So let's talk about the pediatric algorithm. That you're seeing my screen, so I'm recognizing maybe Clayton can help me get this bar off. Do I just click on it to get rid of it? You're not seeing the bar? Okay.
You don't see a bar, Brina.
So it's just my bar. Okay, so this algorithm, which I think we learned a lot together last year, had to be updated, and we updated it in a few ways, and we're going to go through it today. I really, really, really have to say over and over to all of us, this is a clinical decision-making tool. This is not for parents. It's not for community members. It's not for non-nurses. And it really is meant to improve communication between you and the child health professionals in your community to decide how to get kids back to school when they've been ill. And one of the ways we've been successful as pediatricians in the last few weeks during a very messy time about masking is to talk about a shared goal that everyone can see themselves in, the goal that we want more children in in-person learning. So as you begin to work through the algorithm, the goal is to get more kids back to school. It is not to exclude more kids or to try to, to have this really, strict process. It's trying to get more people in, but in doing so, we have to be very team-based. And there has to be a lot of communication between you and parents and your local healthcare professionals. The fact that it's a living document comes up every day. We have committed, as the infectious disease doctors Bill and Ben, plus Becca Bell from the AAP and myself, we are only going to update it at every 2 weeks. Now that we have this copy and version, it took us about 16 hours in the month of August to take in all the feedback and keep trying to get it right. So it's imperfect at best. And I did want you to remind you that we have parent and child care companion documents that are generalized, there are for use with the public. And they have taken the algorithm and turned it into a handout that is not as clinical, but still tries to impart the general intention of the algorithm. And uh-oh. Okay, I'm dangerous. Here we go. So the two major things that had to happen, and then there were some nuances. We had to do pathways to reflect some people are vaccinated and some aren't, even in our pediatric population. And we really had to increase our recommendation to drive more children to testing with even minor symptoms. We know that means there has to be more testing capacity in your communities, and we need you to tell us real time. And when I say us, it can either be your public health colleagues, Elisa and Nate and Caitlin, or me. And everyone knows how to reach me, but I'm still supporting this role through the American Academy of Pediatrics, because if testing's not adequate, this whole thing breaks down. Okay, let's talk about the algorithm. Graphic design is tricky. And in order to get the right information on this page, the font got smaller and smaller, but I encourage you to never print this document because it will change. I would encourage you to keep the link at ready, but if you print it, you risk that it's been updated. And, as evidenced by some things that have already happened this week. So up at the top, we remind us that this is for clinical decision-making. We remind us that this is a changing environment and that this is not for kids who have had COVID within the last 3 months. Because the confirmed COVID cases, that's a very complex decision about when to test them. And you may recall that from your time last year. There are risks of persistent positive PCR in the context of a previous infection. So if this first page is about if you've been exposed to COVID, it has much more language than the second page. If you've been exposed to COVID and you have symptoms, you need a test. So in the old days, we, sort of tried to decide which symptoms were more consistent with the COVID we knew to be true in pediatrics in March and May of 2020. It has turned out that COVID in children, especially in Vermont, there are about equal weighting of about 5 or 6 presenting symptoms, including runny nose. So we don't feel anymore, the infectious disease doctors don't feel that we can do any kind of clinical batching, that if it's cough and fever or if it's runny nose and fever, that would lead toward a more suggestive presentation to warrant a test. So that's tricky. And we know that's going to be, parents are going to say, no, this is just a runny nose. And you're going to be in that difficult role of saying no, because now we have so much COVID, Delta variant, and we've learned more about our pediatric experience. We think you need a test. So I'll talk more about that on the second page for kids who haven't been exposed. So after you come through and you see that the test is negative, vaccinated people can go back to school. So that's a very important change, and that heads over to the left side of the page. Now, we went round and round for 3 weeks about resolved versus markedly improved. And we landed on markedly improved so that you have some clinical decision-making capacity with your nursing degree and also with your clinical partners in the community, because we couldn't put we wouldn't get kids back into school if we were so rigid to say you had to be completely resolved, because these are kids with a negative PCR and they've been vaccinated. If the child has not been vaccinated and they're exposed to the ongoing COVID exposures in the home, these two pathways have stayed the same, and many of you worked through these last year. This is this complex thing about when you can get tested and when you can go back. And I will just leave it there because it's too hard to do verbally, but really no, we're here to support you and your clinical colleagues if you have that scenario that there's an unvaccinated child who has ongoing exposure. And if the person does not have ongoing exposure, then they just have to be well, come back. A positive test is the normal pathway, nothing's changed. There's 3 criteria to get back to school. You have to have 10 days since your symptoms started. You have to be without fever for 24 hours, and you have to have that resolution or improvement of symptoms. The asterisk next to positive tests takes you to the bottom to remind you return to play is an important part of COVID recovery. And I'll talk about that in a second in one of the questions that came up. If you've been exposed to COVID, now I'm on the right side of page 1, and you do not have symptoms, vaccinated people need a test at day 3 to 5. That's it. And then if the test is negative, they go back to school. But if you're not vaccinated, you have to take this is the traditional pathway we worked through last year. Depends on whether you've had exposure in the home. Lots to say here. Just a reminder that this symptom improvement piece doesn't work for loss of taste and smell. And that's a footnote that is not able to be read. Okay, let's see if I can advance. So this page changed dramatically because this was the page where we really in the past drilled down on trying to use symptom combos to determine likelihood of COVID. That's all gone now. Now this may change in November when we get a handle on Delta, but right now, any kid, this is not an exposure page, there's been no close contact, but you have all these kids with symptoms. If the symptoms are less than 24 hours and they resolve, they can come back to school. If the symptoms persist more than 24 hours, we'd like those kids tested. And then we added this caveat on the left. Go ahead and get that test before 24 hours if you want to get going on contact tracing. So early initiate, like finding out someone has COVID the first day is of great value to all of us. So there's really no reason to wait the 24. We were just trying to be balanced that not every family is going to rush for the test, and that if the symptoms go away in a day, you're good to go. So this one's tricky. You can picture Bill and Ben going round and round about this. You as a clinical decision maker with your pediatric colleagues can say, you know what? I think these symptoms are consistent with Vermont's experience with COVID, fever, cough, runny nose, headache, and loss of taste and smell. We put those in there to say, go ahead and drive families toward a test sooner if it just sounds like COVID to you. And when I say sounds like COVID, it's those symptoms. And so we're trying to make a distinction here that you don't have to send every kid with fatigue or a headache over, but I'm sorry, not headache, because that's a good one to get tested, like fatigue or diarrhea. But if you've got these respiratory symptoms or the fever, get the test. So we're just trying to say, get the test, get the test, get the test. But we're giving this one little out that you can wait a day if things resolve. And then we added this other bullet, ongoing concern about transmissibility. Like right now, every pediatrician I know is telling every family with any of these symptoms, go get a test. And then the disposition of that test result, this really hasn't changed. I think it's a little confusing that we have what to do if it's negative, what to do if it's positive, and then we add this weird thing that despite our recommendation to get a test, there was no test. And that's because we do have healthcare professionals among us who decide this kid has croup. And I don't think they need a test. And, you know, we're not really, and this algorithm is not intended to be some sort of rigid, you can't let people be physicians. Do you know what I'm saying? So if someone comes in with an alternative diagnosis made by a medical home, they can return under those circumstances. And then if they didn't test and there is no diagnosis, that child is treated like they have COVID. Greater than 10 days since symptoms, resolution of fever, and symptoms almost resolved or markedly improved. So just a few more slides and then we'll open it up. This is ongoing. We're meeting tomorrow at 8 o'clock because the pediatricians found a pathway in that algorithm I just described that's too long. And I need to get the epidemiology people at the health department to sign off on a change. So all last year we said, well, we didn't say unvaccinated, but we said if you're exposed in the home and you have a negative test, then you can't test out at 7 days if you have symptoms. So that's on that first page on the far left side. We said, I'm so sorry. You're in a house with COVID. You're going to have to wait it out until what ends up being, it can be that you know, were noted to have it 10 days after your household had COVID, and then you have to do a 14-day quarantine. There was no test out at day 7. And Epi really just said that's just because you're in a house with COVID, you have to stay home. But the pediatricians are worried that that's 24 days. There's a really long pathway. And their argument is there's so many other respiratory viruses going on. It does seem plausible that those symptoms could be from a different virus if they, you know, they tested negative. So when should they get another test? You know, this all has to be worked out tomorrow. So if you find yourselves in this scenario, hold tight or call us. And then there's another place we're gonna add a footnote. In the old algorithm, we said if you're exposed in the home, you can, and you don't have symptoms, you get a test at day 7. And now the pediatrician is saying, don't wait for day 7. Go ahead and get that test sooner. So there's just these little nuances that might not be that recognizable to you, but I wanted you to see that anytime you go down a pathway and your particular patient and scenario doesn't make sense, we need to hear from you because we're almost trying to do too much with this algorithm. And the pediatric leadership is right on the brink of just really wanting to partner with you and talk about these things rather than try to make a document that's going to answer all the subtleties. Hope that makes sense. So Clayton sent me a few questions. If a student wakes up on Tuesday with a fever, but the fever doesn't last into the next day, they're eligible to return after 24 hours. That is correct. This person goes on to say, I appreciate the opportunity for watchful waiting, but that should be done under medical guidance. This is putting the responsibility on parents. I feel parents are just going to say, oh, they're better and send them back. Parents aren't honest about their kids' symptoms, and without the safety net of the previous guidance of if 2 of the symptoms in the yellow box, that's the old algorithm, or out for 10 days. So that there was something in the old algorithm that helped this person that sent in this question. At this point, because it's clinical decision making, you as a school nurse could say to the family, you know, fever is a symptom of COVID. And even though it only lasted a day, I think you need a test. But by strict criteria of the algorithm, if the fever's really gone, they are allowed back in the school. So, but this question brings up much more and things we've talked about together all year, which is this parental, you know, the relationship and the team that you are building around all of your children, their parents and their pediatrician is going to have, it's a sieve, right? There's going to be cases that fall through because of the complexity of our society. So I try to normalize for people all the time that COVID happens. And there is no, full barrier to keeping COVID out of your school. So if something like this happens and somebody's not honest about their child's symptoms, or there's a masking of the fever, or all the things we know to be true about infectious disease, then that just is. I don't think our algorithm can help mitigate that. A second question came in: is the return to play still in place? The last memo from AOE was 6/6/21. Prior to the emergency order, we have families pushing back saying we can't continue this because there's no emergency order. I was so happy for this question because return to play has nothing to do with the emergency order. It's pediatric cardiology advice to pediatricians about what they need to do with a patient who has had COVID before she returns to play. So I hope that's super clear. Return to play is completely still a thing. Nothing has changed about it. And all the children that you've heard about or are working with that have COVID need to see their medical home to decide what their disposition is about athletics over the age of 5. That said, our contact tracers have been told, and they're working harder to say to every patient with COVID, you must talk to your medical home, which checks several boxes, because many, many pediatricians don't know their patients have COVID. I know you also feel in an information vacuum. So that helps contact tracing remind people that that has to occur. And then this came up on one of the VCHP Champ noon, the 12:15 call a couple Wednesdays ago. Someone asked about over-the-counter PCR. I hope you're tuning into this new thing people say, NAT, the nucleic acid amplification test, which is just a broader way to say polymerase chain reaction. It's another nucleic acid is the gold standard of COVID testing. They now do exist over the counter. So the question was, is it acceptable? What about Walgreens? I started to say the whole algorithm is about PCR, which is true, because I thought the question was about antigen, which I was wrong. And then Ben Lee, this is why we love our call, Ben answered, the test has to be a PCR or a nucleic acid amplification, but they are available now in the home and possibly at Walgreens. What I will say about this is concerning from an equity lens, because they're not covered, they're not free in the state system like the pop-up PCRs that take hopefully only 2 days. So there's a cost to families, and I've heard in the range of $160, $200 out of pocket. Okay, I'm going to stop sharing. I'm going to see if that just made it harder. And I want to just state again that there's 3 things going on here. We need kids in school. We have to keep the virus out of the building. And we have very, very stressed parents who don't have parental leave. They don't have choices for caring for their children if their illness is prolonged. So in all of those contexts, the true algorithm should just say, go get a test. It's that simple. But people wanted a little bit, especially the pediatricians wanted to say, but I'm not sure we can handle the volume that every 2 seconds one kid vomits, everybody races to test. So we had to do that little teeny column of if it's really just a day. But if you're asking me now as non-state government, just bring if children have any of those symptoms, they need a test. Then if you're in that who has COVID, who's in the household, I just don't think the algorithm is as helpful as it was last year. I feel like there's too many nuances, but I still want you to try to take it through and see if what Ben and Bill put in there helps with the disposition of what you need to do with a patient. But if you can't get there with those boxes with your eyeglasses on, call us. Or come on to the 12:15 call, which many of you have signed on to now with the pediatric teams, because Clayton can confirm this. Pediatricians just put in like a left-handed person went to Florida, came back, had vomiting. You know, there's a very complex set of clinical decision-making going on in that call with Ben and Bill. So we have this, you know, I just think Vermont's remarkable that we have this level of connectivity between us. And I also wanted to recognize that sometimes school administrators get called in from parents being frustrated about the illness return. And I feel like your pediatrician colleagues are really good teammates in those difficult conversations, which I think you all know now, but they've made quite a commitment the last month to those school board meetings about masking. It's been pretty sort of heartwarming and horrifying, which I'm sure you're witnessing, that we have this committed group of pediatricians who really want to help kids stay in school. Okay, Becca, what's going on in the chat? You're so good at chat.
So,
One last thing, sorry,
Oh.
because Clayton's going to ask me. Remember there was an adult algorithm?
That's in the chat. So yeah, go ahead and address that.
So we have adult infectious disease doctors worked very hard a year ago to get, it was November actually, to get something for you really, because other adult employers do their own sort of employee health, but we needed something for staff and teachers because it was not, and so we took responsibility for it even though we're pediatricians. She's on service for 2 weeks at UVM hospital right now, and she wrote to me last night and said she can't look at it till next week to update it on the sort of vaccine. But my advice to you, just as a physician, is if a staff or teacher has any of those symptoms, the symptoms are all the same now. We used to think pediatrics was different with this virus, but it's not for symptomatology. They just need tests. So, but I imagine you're going to tell me, as a person who gets some pushback, you're going to need something like that having that handout would be of value. So we're going to still get you something. It's just never with the urgency we do with children, even though I know a lot of your cases are in staff already. Okay, sorry about that, Beck.
That's okay. So can children still test out of quarantine after 7 days if exposed, but they don't have symptoms? That's the first question.
100%. So what's glitchy for tomorrow morning is that we don't offer testing out for kids who have symptoms. So they're stuck at home for 14 days, which is just not going to be good when we know kids have RSV, rhinovirus. We've got to figure out a way to let them get a test that's not, says they don't have COVID. There might be a little runny nose and they go back to school. But that's not there yet because Epi said if you're in a house with someone with COVID, you need to stay. This was before kids were, had all these runny noses. So I don't know how that feels. I just know when the pediatricians did the math yesterday, it risks a 24-day, because you don't start as the exposed person, your 14-day quarantine until, the person that is no longer exposing you, which would be day 10 of the person with the illness. Does that make sense? I'm sorry to do the math verbally. So feed back to me how that feels. I just know that if we don't have a pathway for testing a kid who's symptomatic when he's exposed to COVID, then we're just assuming they have COVID. It isn't really fair to the education of that child.
Okay, so our guideline used to be don't return to school until you have a test result. But if a student tests and the symptoms resolve before the results are back, is it okay to return before the result comes back?
If they're vaccinated, yes. If they're
So 12 and over
unvaccinated,
if they're
no.
vaccinated.
Vaccinated people don't quarantine when they're waiting for their test. That's true of all of you.
Even if they're symptomatic?
No, not if you're symptomatic. If you're just getting a test for exposure.
But I'll give you a personal example. I stayed home on Monday. I had a sore throat. I went and got tested, but it took me 3 days to get my test result back, but my sore throat had resolved. So if you're vaccinated and your symptoms resolve before your test comes back, you can go back to school.
Yes, if you've gone 24 hours without whatever the symptom it was that led you to the test.
That's clear. Thank you. So should we recommend said exposed family member get tested right away and then again on day 7 if they have been exposed in the home?
All right, let me pull this up so I don't misspeak here. If you are exposed to COVID and you don't have symptoms, so am I on the right track so far? Exposed,
Yes.
no symptoms.
Yes.
Vaccinated, you get test day 3 to 5. It's not day 7 anymore. So are you talking about a close someone? Let me pull up. Do you want me to pull the slides back up again?
I think they want to know. So if they were exposed, but they're unvaccinated, because the unvaccinated people are the people that have to wait. If you're vaccinated, it's just 3 to 5 days. But the unvaccinated still would have to quarantine.
That's actually no change from no change from last year. See if I can take you through that because that's an important one. Okay.
I think the question here, though, is not about days. It's about should we have them test right away and then again after the waiting period?
Oh, yeah. So thank you. Gosh, my goodness. That's what the pediatricians are trying to add one more footnote. That was what I was trying to say at the bottom half of that. Yes, that the true clearance to go back is day 7, but you should find out right now if you have COVID so you can get going on that process. So we were trying to figure out how to add it into that part, those boxes. Because last year we didn't say that because we're like, just wait till day 7. I'm sure you don't have COVID. It was so minimally transmitted and so few people within a cohort were getting it. But this year, yes. So we're going to add it as a footnote. It doesn't preclude just figuring out if you have COVID right now, but you can't get out of your quarantine till it's been 7 days. But it would be good to know if you had COVID today. Does that make sense? Ricky.
Our next question isn't about the algorithm, it's about return to play and how we gain documentation. Does the school need to ask for this from a pediatrician's office, or are the school nurses responsible for obtaining that before they return to PE? Is it something we just educate parents about? Could you give us a little bit of guidance as to from your pediatrician?
So this was kind of this was not our best pathway last year. This was messy. The pediatric cardiologist made documents that had a signature at the bottom of a school personnel implying that someone had to sign off on, from a school perspective, that a child had done the return to play, but that was never the intention. We do not think that schools, all we need to know is that parents were educated by their pediatrician that this was important and that teams can decide, meaning team-based care in a community, how do you want to figure out if a kid's done this? Some schools have the capacity to use school personnel to check in about that, and some of our smaller schools or schools without athletic trainers don't have the capacity, so it had to be that it was the student themselves or the parent attesting to it to themselves. It wasn't like a check. So it really is not the responsibility of the school. This is medical advice from a pediatrician to a kid that has had COVID and his parents that you need to be slower getting back to the field or the PE. That said, and that question came from Amy, if you were not a part of that last year, then it will just be like that. But if there were communication glitches, we encourage a team meeting, which school nurses really can convene to say to the local pediatricians, what do you want to do about this? Because it feels to me that parents get caught in the middle of it a little bit, because not all parents have the agency to carry the information. So we've been trying to think of an analogous thing where there's something a pediatrician tells a kid to do that it would be good you knew, but you don't need to have like the ownership of it. Very hard. Athletic
Thank you.
trainers have been doing a fair amount of, collecting of forms. There's tons of forms on the website. The VCHP call website has the forms if you want to use them, but there's no requirement.
Marina, is it okay if I
Okay.
ask?
Sorry, no, we gotta move on. Sorry. We can have let's have another town hall just about return to play. I think that's a topic.
Oh, that's a good idea. Yeah, bring the Jonathan
So back to
flyer.
the algorithm. We've got some questions about the algorithm. We have just shy of 10 minutes left. So we've been told that we can ask for proof of vaccination when we're doing contact tracing, or we can ask them if they have been vaccinated. And then also, because we can't access the immunization registry for COVID, our school districts have been encouraged to get a parent attestation that their child has been vaccinated. But this question is, can we ask for proof of vaccination in the event the child has symptoms?
Yeah. I mean, you guys know my life belief. You're part of the medical team. It's a medical question. It's not a political question. You're assessing the health of a child, and you need to know if he's been vaccinated.
And if they don't want to share that with you, you can give them both options. You can say, if you're vaccinated, this is what you do. If you're not vaccinated, this is what you're going to do.
That is correct.
So if a student is fully vaccinated and asymptomatic and has had contact with a family or household member who's positive, where there's potential ongoing exposure, does the vaccinated student need to quarantine, or are they okay to get tested initially and then again 3 to 5 days later? And then if they're negative, they're good to come out?
Okay, I think I need to pull up the thing again. And Becca, you can read it again as where the only thing I know for sure is to slow down and go right to the path. So
This is good practice.
read it to me again. Person
So
is
we have
exposed
an
to someone with COVID.
exposed child. Yes, they were exposed to COVID in their
Symptoms?
home.
No
They
symptoms.
are asymptomatic, so
Nope.
no symptoms.
Nope. Vaccinated?
And then they are vaccinated.
Yes. Whoop.
And
They
then
need a test at day 3. They can go to school when they're waiting.
so it doesn't
But they have to
matter
be
that
masked.
they
Yep.
were exposed in the home. Like if you went to no, and then it says exposure in the home. It-
Right. So we opted not to have a pathway that vaccinated and exposed in the home. At that point, it's okay. It's just this one test for a vaccinated person is enough. And they go off to school, and then the test comes back. And then if it is positive, you have your own pathway. The only thing we added in this, see the footnote 3, if there's ongoing exposure in the home, test 3 to 5 days after the initial exposure, and then again 3 to 5 after the last exposure. Like if you really can't stay away from the person with COVID, you can go to school with your mask on, but you're going to need a follow-up test, after the last time you were exposed. But the real advice here is get away from the person with COVID. So we think this particular scenario is rare, but probably needs some pretty special attention. What if they really are a kid who can't be away from the person with COVID, but they're vaccinated? The team feels very comfortable with them going to school. And that's because it's 0.2% of people who are vaccinated get COVID, right? Still, even though we're hearing tons of anecdote about that, it's still a rare event.
Thank you. So the importance here is the footnotes. So please also read the footnotes. Nathaniel Waite put in a lovely link to, in addition to the algorithm, there's a website that goes over close contact testing recommendations. So please use that resource as well. And then the question here is about where do we land on staff and close contacts? Do we take their word or ask for proof or treat them as unvaccinated? So the answer to that question is, sorry, Brina, I'm just going to cut you out, cut to the chase. So the answer to that question is you can ask them if they're vaccinated or not. If they say they're vaccinated, we take them at their word. If they say they're not vaccinated, or if they choose not to tell us, we treat them like they're unvaccinated, or we can give them both options and say, if you're vaccinated, this is what you do. If you're unvaccinated, this is what you're going to do. But you are allowed to ask any staff member who's a close contact if they're vaccinated or not. I think that's the end of our
Good
questions
job,
in the chat. With 3 minutes left. So thank you, Brina, for all of your consistent support and cheerleading and everything you do behind the scenes to help support us that we don't even know what you do, like the many, many meetings and advocating for us that you do. So we couldn't have done or been here without you. So thank you. One more question.
Well, I feel the same way about you.
Oh, sorry. One more question. Do we require vaccination proof from anyone, staff or students? So we cannot require them to show us proof. It's based on honesty and their word.
Self-attestation. Well, I'll just end with saying that I just really want you to feel the support, because I don't think this is easy to do without a team. And I feel that the first week of school has already taught us that we have a lot of need for teaming and a lot of complexity here. And but Ben and Bill are right there. I mean, they are so remarkable in their study of what's happening with the literature, trying to understand what to do to keep kids in school, right? So if we stick with the goal together, then we won't feel that there's this constant tension about all the policies beneath. It's just like, let's work together to keep the COVID out of the building, but really to keep kids in school. So
absolutely,
just want to acknowledge that the algorithm has some simplicity and some complexity, but it's our best attempt for right now. And I imagine we're going to be back talking to you about it in a few weeks. Well, invite me back, because I am
we always will.
Yeah,
we'll always invite you back
together.
Well, thank you so much,
Right.
Brina. I do want to reiterate what Brina just said about how it's easy in our jobs to be overwhelmed by all that we have to do, especially given all of the information we were just presented about surveillance testing, etc. But we are not alone. We have many teammates that we can rely on, including the surveillance panel that was here today. Please use the resources they've offered us, lean on them, communicate with your superintendents about what is going on and what work we need to do. If you can't do it alone, you need to get a team around you. So please reach out to your local support systems and create a team if you don't already have one. Thank you for coming today. And again, our next town hall will be Thursday, October 14th.